Paul Logan here. Let's get started with part 2 of cardiovascular problems. And to start with, I want you to memorize this, because when you understand this image, you understand a ton of cardiovascular physiology. The timing is everything when we're talking about the heart. And so using this, you can combine aspects of the EKG, the physical exam, and understand exactly what's going on in the cardiac cycle. So we will start with this important component, which is the P wave. Notice that with the P wave comes atrial contraction, and we can see that reflected here on the ventricular volume, because when the P wave happens, atrial contraction occurs, and that increases the volume in the left ventricle, right? So that really tops off the left ventricle. Then the beginning of the QRS complex, which corresponds with the first heart sound, or S1, begins this period of isovolumic contraction. Now, I want you to understand this because it becomes very important when we're talking about aortic stenosis. No blood is ejected from the heart during this period of isovolumic contraction. What's going on instead is that when the ventricle contracts, the mitral valve closes and the tricuspid valve on the right, and that allows the pressure to build up inside the heart until the pressure in the left ventricle overcomes the pressure in the aorta, right, or the blood pressure. So this period of isovolumic contraction is just contraction of the heart and increasing the pressures until the aortic valve opens, right? So until we get to this point, there is no blood flow in the heart, or out of the heart, I should say. Then when the pressure is greater than the pressure in the aorta, now the aortic valve opens and ejection happens into the aorta. And then this period of isovolumic relaxation happens when the aortic valve closes until the mitral valve, that's the AV valve, the atrioventricular valve, which we don't talk about in clinical medicine, but the mitral valve opens and allows atrial filling. So notice there's two kinds of atrial filling. There's this passive atrial filling, ventricular filling, that happens when the pressure in the atria are greater than the pressure in the ventricles. And that passive filling is the first thing to happen. Notice if there's a huge volume of blood from heart failure, for instance, that passive ventricular filling can make a third heart sound. And that is exactly what happens when you have severe left ventricular failure and there's a huge volume of blood stuck in the atrium. As soon as the mitral valve opens, that blood falls into the ventricle and it makes a thud. And that thud is a third heart sound. So that's the first part of ventricular filling. The second part of ventricular filling happens with the P wave, right? So when the P wave happens, atrial contraction occurs, and that's when you really get the topping off of the ventricular volume. And remember that atrial contraction contributes somewhere in the neighborhood of 20% of the entire cardiac output. That's not insignificant. So that's the cardiac cycle. And you can refer back to this as we talk about things like aortic stenosis and mitral regurgitation and everything that the heart does, because this is really the basis for understanding all of it. The other basis for understanding what's going on in the heart is the pressure volume loop. So in this slide, it's important to remember that left ventricular pressure is on the y-axis and left ventricular volume is on the x-axis. Now, time is not represented here anywhere, right? So because we're moving from left to right, that does not mean anything about time. What is being reflected here, if we start at this point, is that the left ventricular volume increases as passive ventricular contraction happens as the atrium dumps blood into the ventricle. And that volume increases along this x-axis. But notice the pressure doesn't really change in the ventricle until atrial contraction happens. And that's where you get this little bump up of pressure and volume. Now, what happens at that point is ventricular contraction begins, and that's what closes the mitral valve. So the mitral valve now closes, and during ventricular contraction, that pressure increases dramatically. Remember, this is isovolumic contraction, which means that there's no blood moving. Notice that the volume is not falling here during this period of isovolumic contraction until the aortic valve opens. Now this is the period of ejection, and the pressure continues to go up, but the volume is decreasing until we get to this point where the volume has fallen off substantially and the pressure begins to fall. Now the aortic valve closes because the pressure in the aorta is higher than the pressure in the ventricle. And now the period of isovolumic relaxation begins. And during that time, there is a tremendous drop-off in pressure inside the ventricle. And then when the mitral valve opens, that begins the period of filling again. So that's exactly what's going on in terms of pressure and volume in the ventricle during the cardiac cycle. When you understand that, you've added to your understanding of physiology, and that will come in very handy as we move forward. So let's begin by talking about cardiomyopathy. Now, essentially, we're talking about cardiomyopathy because we're later going to talk about heart failure, right? And to understand heart failure, we need to understand different reasons that you would have heart failure. And that's what the cardiomyopathies are. They are reasons that heart failure occurs. Now, remember that we can divide heart function for the purposes of heart failure and cardiomyopathy. We can divide it into the systolic function and diastolic function. Systolic function is what happens during systole, and that's during the squeezing or the contraction of the heart. Okay, that's the inotropic phase. We measure systolic function by ejection fraction. So what is the percent of contraction that happens? You have a big circle at the beginning of systole and a little circle, if you outline the heart, a little circle at the end of systole. And if you look at the percentage change, that's what we're talking about here. Okay. So a normal ejection fraction is not 100%. You would not want to have 100% ejection fraction. Normal is 60, right? And even in the 50s, we're willing to accept that. But the definition of normal, according to the American College of Cardiology, is 60 to 80%. We say a ventricle is hyperdynamic when it's above 80%. And we have 3 different grades of reduced systolic function. Mildly reduced is 40 to 50%. 40 to 49% is the real thing. And then moderate is 30 to 40%. And severely reduced LV function is less than 30%. Okay? Know those numbers because that's important for you to know as a clinician going forward. That tells you how severe someone's cardiomyopathy is. All right, so that's systolic function. That's what happens during ventricular contraction. But let's talk about diastolic function too, because that's a thing, and that's important for us to consider when we're talking about heart failure and such. So diastolic function you can think of as the compliance of the heart. How well does it expand when it's filled? So think about 2 different kinds of balloons. You have the party balloon that you can easily blow up, and then you have those annoying balloons that you can shape into animals that are completely impossible to fill, right? Have you tried blowing those things up? It's impossible. The reason is that they are non-compliant. They don't have good compliance. Unlike the party balloons that you can blow up all day long, those are very compliant. So the reason that we care about compliance is that a compliant ventricle fills well, right? It fills up with blood very well, and that contributes to normal heart function. But when a ventricle is thick, remember hypertrophy is the response of the heart to pressure overloads over a period of time. And when we have a thick hypertrophic ventricle, just like those bodybuilders who can't relax, right? They're always running around the gym going, yeah, let's go pump some iron, right? They're annoying. The same thing is true with a thick hypertrophied heart muscle. It can't relax either. It can't just sit still and relax and fill. And so that is what we're talking about with diastolic function. The ability of the heart to relax, which in turn allows it to fill very well, okay? We report this on the echo by talking about the diastolic compliance. There's grade 1 diastolic dysfunction, grade 2 diastolic dysfunction, those kind of things. So before we get into anything else, we need to differentiate the types of big heart, right? So we can say that you have a big heart, meaning that it's dilated, or we can say that it's hypertrophied. Now, those are two very different things. Notice the normal heart here in the middle. Well, a hypertrophied heart is where the muscle is thick. You see, this muscle is very thick compared to the normal. And as that muscle gets thick, it makes the cavity that you see here much smaller than normal, right? So this hypertrophy is one phenomenon that happens. And this is that cellular response that we talked about the first week. It's one of the cellular adaptations. And we see this when the heart is tasked with having high pressures to work against. Hypertension, aortic stenosis, things like that. Just aging as well. But that is different than dilation. Dilation is where the heart muscle thins. You see how much thinner that is than here. And that thinning of the free wall here happens as the heart muscle weakens and gets bigger. It makes the diameter of the ventricle much, much greater. And that increased diameter is what we measure when we're talking about dilated heart. Okay. And we talk about those two types because there are two different types of cardiomyopathy. So the dilated cardiomyopathy is primarily a contraction problem because the heart muscle has thinned as it's gotten bigger. It doesn't contract well, and therefore it can't send out enough blood flow. Okay. Contrast that with hypertrophic cardiomyopathy, where the heart muscle is real thick, and as it thickens, it narrows the size of the ventricular cavity. It decreases the amount of space that there is for the heart to fill, and it decreases the relaxation properties of the heart. And so it's hard for the heart to relax and fill. Okay, and that means fluid can back up into the lungs as well. There's also a rarer form called restrictive cardiomyopathy from conditions such as amyloidosis and other conditions that are pictured here as the third major type of cardiomyopathy. Now there's these other types as well that we'll talk about: arrhythmogenic right ventricular dysplasia, now known as arrhythmogenic right ventricular cardiomyopathy, very rare. And then there's this other one that is a very commonly seen thing. I mean, we see it several times a year, called Takotsubo cardiomyopathy. Takasubo is the Japanese word for an octopus trap, and that's what it looks like on the ventriculogram when we do it in the cath lab. So let me just show you normal LV function first. This is a normal heart muscle, and this is about what the contractility should look like. You can see the thickening of all the heart muscle here, and that's normal. There's some color. They're looking at the valves there, but we're focusing really just on the contractility of the heart. You can see that this ventricular cavity gets smaller and the walls thicken all the way around. So that's what we're looking for in normal heart muscle function. In a dilated cardiomyopathy, it looks like this. Notice how much thinner the walls are, and notice how big the diameter of the cavity is. That's what we talk about when we talk about dilated cardiomyopathy. And then finally is hypertrophic cardiomyopathy, and look at this. Look how there's what we call cavity obliteration. This muscle is so thick that it actually obliterates the cavity there, and that means that it's very, very difficult for the heart muscle to fill, right? Oops, I switched to the wrong one. So again, this is the hypertrophic cardiomyopathy where the LV size, the LV cavity size is diminished because the walls are so thick. And that means that it's hard for the heart to fill. Now, this can happen because of a congenital condition that's an autosomal dominant inheritance pattern that we call hypertrophic cardiomyopathy, or the classic hypertrophic cardiomyopathy. And then there's hypertensive heart disease that sort of masquerades as hypertrophic cardiomyopathy. There are several different varieties of this. This is arrhythmogenic right ventricular dysplasia, and what you can see here is normal heart muscle. And as the disease progresses, there's replacement of normal heart muscle tissue with fibrotic material. And you can see that on these different stains. And it causes a particular type of ventricular tachycardia. And these patients require specific treatment by electrophysiology as well as heart failure. Restrictive cardiomyopathy, again, there's multiple different things that can infiltrate into the ventricle, and the most commonly seen thing is amyloid. So this abnormal protein that's produced by the liver, and there's different types of amyloidosis. We're not going to go into all that stuff, but what this does is it produces a restrictive filling pattern where there's something that's preventing the filling of the ventricle. So it has some characteristics of hypertrophic cardiomyopathy, but it is a different entity. Takasubo cardiomyopathy is also known as stress-induced cardiomyopathy. This is that classic syndrome known as the broken heart syndrome. When people have a tremendous catecholamine surge, we theorize, such as the death of a spouse or some other trauma, you can have this transient cardiomyopathy. It looks just like an acute MI when we look at it on EKG. Patients have chest pain, the whole 9 yards. They have decreased LV function, but it's transient. It comes back. I had a patient, the first patient I ever had with this, this was probably 20 years ago, but she was at work and she was sort of an emotional person, I remember, and her boss got furious with her and screamed at her and humiliated her in front of everybody at work. And she developed chest pain during that and ended up going to the emergency room. She had ST elevation and looked like an acute MI, took her to the cath lab, normal coronary arteries, right? Found no blockages in the arteries at all. And nobody really knew what to make of it except that she had this syndrome. And about a year later is when the the investigators at Hopkins published their study defining Takotsubo cardiomyopathy, or redefining it. It had been described before that, but it wasn't really on people's minds until later. So Takotsubo, you'll probably hear that in clinical practice. Now you know what it is. It's transient, gets better in time, typically affects women, but certainly has affected men as well. All right, so all that stuff is a setup for talking about heart failure. So let's talk about different kinds of heart failure. We have to first discuss the fact that we have different ways to classify this, right? Sometimes we talk about high output and low output failure, left versus right failure. And by the way, can you teach people that this is verses, not verse? It's one of my little pet peeves in life. My kids say left verse right. Drives me crazy. A verse is something you sing in church, right? Not what you use here. Oh well. All right, I digress. So we have these different descriptions of heart failure because it helps us to sort of classify things in our head. So high output failure would be something like pregnancy, where you have this massive increase in blood volume, but you're a little anemic, and so your heart has to work a little faster to deliver oxygen to the body, right? Because you have a 50% increase in plasma volume, but not an increase in red blood cells. So your blood is kind of dilute when you're pregnant. And so this causes this high output state. We can also see high output failure with hyperthyroidism and some other conditions as well. It's often convenient to describe heart failure in terms of left versus right. So you can have biventricular failure, but oftentimes we see right heart failure independent of left heart failure, right? We just see neck vein distension and peripheral edema with no involvement of the lungs at all. That would be right heart failure. We also sometimes see left heart failure where there's just crackles in the lungs and no neck vein distension, and no peripheral edema. So it's often convenient to talk about left versus right. It's always convenient to talk about systolic versus diastolic failure. Is it a pump problem, which would be systolic, or is it a filling problem caused by diastolic noncompliance? That's very important. And then we now, every 5 years you have to change the terminology, right? So now we don't talk about systolic versus diastolic, except we still do. But in the literature, you'll see it referred to as heart failure with reduced ejection fraction, that's systolic failure, versus heart failure with preserved ejection fraction, or HFPEF. So we do that as well. Talk about forward failure, backward failure, compensated, uncompensated, all sorts of different descriptions. It's important to know how we communicate in the medical record about heart failure. So it's important that we have a way that we can tell where is this person in terms of their heart failure today. So the New York Heart Association functional classification system was established 1 million years ago, and it has 4 different classes. So when you have class 1 heart failure, you have no limitation of physical activity. When you have class 4, you are symptomatic at rest. Okay. And then there's 2 and 3, which are in between. And that's the whole idea is having cardiology people figure out what functional class you are. But you can come into the hospital in class 4 heart failure and we diurese you and make you better. And then you go home in class 2 heart failure. And then you're readmitted again with class 3 heart failure. And so we needed a way that we could sort of tell across the continuum, what is your heart failure? Well, that is the AHA-ACC heart failure classification, and these are what we refer to as the stages of heart failure. So stage A is someone who's at risk for heart failure. So who might that be? Think to yourself, who might be someone who's at risk of heart failure but hasn't had heart failure yet? Well, how about hypertensive patients? How about diabetic patients? How about patients with kidney disease? Any of these are appropriate as stage A heart failure. They have risks for heart failure, but they haven't yet had heart failure. Stage B is structural heart disease without signs or symptoms of heart failure. So if somebody has left ventricular hypertrophy, for instance, or if they have aortic stenosis or severe mitral regurgitation or whatever, but they don't have any symptoms of heart failure, then they're classified as stage B. You can't go backwards. Once you are classified as stage B, you can't go back to stage A. That's not true in that New York Heart Association classification, right? So if you are stage 4, you get diuresed, you go back to stage 1, and then you get seen in the office, you're stage 2. You can bounce all through these because it tells me today, what am I? Well, this staging system tells us where are you on the continuum. So, 5 years ago, I had structural heart disease, but without signs or symptoms of heart failure. Today, I have structural heart disease and I've had heart failure either currently or in the past. And, in 3 years, I'm going to end up in the ICU with a swan getting staged for or getting studied for potential for heart transplant. That's refractory heart failure, and you can't go backward from that, right? You are always class D after you get to that point. All right, so that makes sense? Good. So the pathophysiology of heart failure looks like this. We have increased peripheral vascular resistance that gives rise to increasing afterload. The increasing afterload makes it harder for the ventricle to do its work, and that stimulates the neurohormonal changes of the central nervous system, the sympathetic nervous system specifically, and the renin-angiotensin-aldosterone system. And what that does is further increase vascular resistance, right? Because it's making you hold on to sodium and water and yada, yada, yada. Then there's hypertrophy that results from that and the increased myocyte demand for oxygen. I want you to focus on that for a second because at the end of the day, that's what we're interested in addressing. We want to address this with the renal angiotensin aldosterone system. We want to address the sympathetic nervous system issues. But at the end of the day, what we're really interested in is reducing myocardial oxygen demand. Okay? When we do that, we can impact ventricular remodeling and hopefully improve contractility and diastolic function as well. Now, we can also have heart failure from myocardial infarction, right? And that leads to an immediate decrease in contractility. So this is all sort of, this is the heady stuff that, that physiologists like to think about. This is what clinicians think about, right? Somebody has an MI, the contractility falls. That means the LVEDV, the left ventricular end diastolic volume and pressure, increase. The ejection, because the ejection fraction has fallen. That means there's increased preload, but there's also increased afterload because of the renin-angiotensin-aldosterone system, and those things both contribute to the contractility. So hypertension and renal failure play roles here as well, but myocardial infarction is the central player in this system. So the compensatory mechanisms that your body has are what we've already mentioned. We have the sympathetic nervous system, which increases the heart rate and the contractility, right? It's easy to increase the heart rate, so that's kind of the way that the heart functions primarily. When you have heart failure, your heart rate increases, which uses more oxygen, which makes your heart failure worse, which makes you use more oxygen. It's a never-ending cycle. We also have the renin-angiotensin-aldosterone activation that leads to fluid retention, which increases preload. Well, when you increase preload, you increase the wall tension, and that increased wall tension makes your heart work harder, and it stimulates growth of the myocytes, and therefore you get hypertrophy, right? It's that compensatory cellular adaptation. So let's talk just briefly about remodeling. Remodeling is this term that we throw around quite a bit, but remodeling is essentially activation. It's activated by these sympathetic nervous system and renin-angiotensin-aldosterone systems, and also by the increased wall tension that happens from preload and afterload increases. All of that has an influence on the cell itself. And you can see that when these remodeling effects occur, it uses energy, right? It uses energy and increases the myocardial oxygen consumption. And at the end of the day, it does bad things. It either causes increased size and function of the heart muscle cells, or it may lead to apoptosis or programmed cell death. So remodeling is something that we would love to be able to influence, because when we do block these things or influence these, we decrease the intracellular energy production and hopefully preserve cardiac cells. The stimuli that go along with heart failure with reduced ejection fraction and worsen that condition are shown here. So there's essentially two phenotypes that are involved. One is the ischemic phenotype, where you have myocardiocyte loss, right, from an acute MI, for instance, and then replacement of those dead myocytes with fibrotic material, and the other cells in response, hypertrophy. That produces this ischemic phenotype that can lead to heart failure. There's also, and this is the systolic heart failure model. The diastolic heart failure model also exists, where you can have fibrosis and insulin resistance and the hypertrophy that occurs that leads to the insulin resistance, and then these electrophysiologic changes as well. And those sort of favor the hypertrophic phenotype. But all of them contribute to both of these, which eventually lead to heart failure. Okay? There are things that worsen this heart failure with reduced ejection fraction, like catecholamines, right? So when we have an increase in catecholamines or increase of circulating epinephrine, for instance, that leads to more contractility of the heart, but at the expense of oxygen consumption, right? So one of the things that we want to do is try and combat this, and we use beta blockers to do that, right? Beta blockers, when I first started in cardiology almost 30 years ago, well, it was 30 years ago. I mean, beta blockers were verboten in heart failure because we didn't want to decrease the contractility, right? That was a dumb thing to do. Well, then we noticed that when we had patients who had tachycardia-induced heart failure, they actually got better when we fixed when we used beta blockers. And so then there were some studies done that used beta blockers to treat heart failure. And guess what? It was hugely successful. And that's what led to the development of beta blockers, which are now a mainstay of heart failure therapy. And again, the reason that we use beta blockers is because we want to decrease myocardial oxygen consumption. That's the benefit to them. We'll take with it what we have to. We'll take the negatives of decreasing the cardiac output, decreasing the blood pressure, all those things that maybe you don't want to, you don't think you want. But at the end of the day, the net effect is that we've reduced myocardial oxygen consumption, and that's the real take home. So this, for those of you who are physiology and physics nerds, you may recognize this discussion of wall tension. So Laplace was the famous French mathematician and physicist who described the effect of wall tension as a function of wall thickness and the radius of the unit that we're using. So he didn't talk about cardiology, but he talked about just flow through tubing and such. And the diameter of the vessel was important. So heart failure with preserved ejection fraction has a different model to consider. Remember that hypertension is a huge contributor to HFPEF, or diastolic heart failure. And the other contributors may be thrown on top of it. Obesity, COPD, coronary disease, diabetes, renal dysfunction, deconditioning, all of those things together can contribute to heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction. Now, remember, left heart failure symptoms are these. The backward effects are the blood backs up into the lungs. That causes dyspnea, orthopnea, PND, crackles in the bases. Right heart failure, the backward effects are fluid buildup in the periphery. So jugular venous distension, hepatojugular reflux, not reflex, by the way, it's hepatojugular reflux, ascites, peripheral edema, those sorts of things. This is a description of the high output failure and why that happens. In particular, in this example, we're talking about anemia primarily, which is impaired oxygen delivery, and that stimulates epinephrine production, which increases the heart rate and stroke volume to increase cardiac output. Because at the end of the day, what is cardiac output? Heart rate times stroke volume. It's easier for the heart to increase the heart rate, or the body to increase the heart rate, than it is to increase the stroke volume, though, right? It's hard to affect that. Cor pulmonale, at the place that I work clinically, we have a heart failure nurse practitioner. And when I first started there, she asked me if I would cover the heart failure clinic for her while she was on vacation. I said, sure. And the first day that I was there, I think I saw 90% of the patients who had heart failure with preserved ejection fraction. Essentially, they had cor pulmonale. They had lung disease that made them have pulmonary hypertension, and they had peripheral edema, and there was really only a couple of patients who had true systolic heart failure. So I joked with her. I said, you may have the only heart failure clinic where everybody has normal LV function, or, preserved LV function. And it's kind of our joke, and I still joke with her about it. But, there's a lot of this disease out there, cor pulmonale. And the frustrating part with cor pulmonale is it's unfixable. Like, there's not much that we can offer. And in fact, we get into trouble. We try and keep people's edema at bay and get enough fluid off of them. But when we do that, we can make their kidneys sick. And it's just a constant struggle to keep these patients euvolemic. Again, that pulmonary hypertension is what backs up blood in the right heart and out to the periphery as well. And this is the mechanism by which that happens. So let's switch gears now and talk about valvular heart disease, which happens to be my favorite. I think it's really important and very helpful for you to think about two significant causes of or two types of overload problems, because it will help classify things in your head. So volume overload problems come from regurgitant lesions. So in this case, mitral regurgitation is shown here, where you have the pressure in the ventricle of 110 millimeters of mercury pushing blood out into the aorta where the diastolic pressure is 75. But there's also this leaky valve that's allowing the pressure from 110 to go out through the 25 millimeter of mercury door rather than the 75 millimeter mercury door, right? Well, which is easier to open? Which door is easier to open? The 75 millimeters of mercury or 25 millimeters of mercury? Well, it's the 25 millimeters of mercury. And so regurgitant lesions like this are a problem because they seek to go out where the least resistance is, right? And that leads to a volume overload problem, okay? Contrast that with a pressure overload problem that we see in stenotic lesions. So the classic example here is aortic stenosis, where there's a pressure gradient between the aorta and the LV. And the pressure in the left ventricle, because there's hypertrophy that happens here, remember, pressure overload problems, the cellular adaptation is hypertrophy. And so that pressure overload increases the intracavitary pressure here, and that makes a gradient across this valve, okay? So the stenotic lesions respond by developing higher pressures to overcome that stenosis, and that higher pressure leads to diastolic dysfunction because of the hypertrophy. When you understand that, that goes a long way toward helping you understand the physiology or the pathophysiology that happens in these disorders. Let's start with aortic stenosis. Remember, this is a narrowing of the aortic valve orifice, and we'll talk about the reasons that it happens in just a minute. But one of the reasons is just aging. So we have this senile calcific aortic stenosis, where as you get older, the calcification of the aortic valve makes the orifice smaller, and it's harder to get blood out through there. Well, when we take these patients to the cath lab and we put a catheter into the left ventricle and a catheter into the aorta, we measure the aortic pressure here, and we measure the left ventricular pressure here. Well, that left ventricular pressure, the difference at peak systole between the ventricular pressure and the aortic pressure is the gradient. So you can see that if we use antihypertensives and lower the blood pressure, we're going to increase the left ventricular gradient across that aortic valve, right? So that is not an adequate treatment for aortic stenosis. In fact, there is no medical therapy for aortic stenosis, but we'll talk about that in a minute as well. So again, the definition of aortic stenosis in the cath lab is where there's a gradient between the left ventricle and the aorta. These two curves should overlap, right? The left ventricular pressure should be the same as the aortic pressure, but they're not. So the reasons that you can develop aortic stenosis are, as I said, the calcific aortic stenosis. You could also get it from rheumatic causes if you have rheumatic fever. Those are the two acquired forms. But there's congenital forms as well. There's the congenital AS that gets repaired in childhood, which we won't discuss. But if you are a patient who develops aortic stenosis in your 50s, you most likely have not the calcified aortic stenosis or the calcific aortic stenosis, but rather you probably had a bicuspid valve, where instead of 3 cusps to the aortic valve, you only have 2. And you can see this normal valve looks like this, right? When it's closed, it has 3 cusps. When it opens, it gives a nice wide open orifice through which all the blood flows. But if you have bicuspid aortic valve, two of these are closed, are fissured together. So essentially you only have this opening here that allows blood to pass through. The rest of this is all closed. The natural history of this disease is that you live for a very long time with asymptomatic state. Then there's this compensatory left ventricular hypertrophy that happens. Still, it's a long time until you develop angina or dyspnea on exertion or syncope. Memorize this. These are the three classic symptoms of aortic stenosis. Angina, that is chest discomfort with exertion. We talked about that before. Dyspnea on exertion, or dizziness, lightheadedness, passing out, those kind of things. These are the things that happen when not enough blood gets out of the ventricle because of aortic stenosis. And if left untreated, it leads to death. Now, how do we measure this? Well, we use the physical exam. And I want you to know, although this isn't a physical exam course, we grade the severity of aortic stenosis by what we hear in systole. The worse the aortic stenosis is, the longer it takes to get the blood out of the ventricle, and so the longer the murmur is. And in fact, if the aortic stenosis is so severe, the second heart sound will be less at the aortic site. That's the right sternal border, second intercostal space, than it is at the pulmonic site, which is the left sternal border, second intercostal space, right? So normally we should hear the second heart sound best at the aortic site, but if we hear it best at the pulmonic site, that suggests that the aortic stenosis is severe. And again, I'm talking about the sound of the closure of the valve, not the murmur itself, all right? P2 greater than A2. The pulmonic sound greater than the aortic sound suggests severe AS. Now, you're going to get, in your career, you will see echo reports. Well, this is what we use to define mild, moderate, and severe disease. When we talk about the valve area, we're talking about a calculation that tells us how big the valve area is when it's open. And so mild aortic stenosis is greater than 1.5 centimeters squared. Moderate AS is anywhere from 1 to 1.5, but severe is less than 1. Now, my aortic valve size may be much bigger than my wife's, right? My wife is, how much shorter is she than me? She's 8 inches shorter than me, and a substantial amount of weight less, but we won't talk about that. So her aortic valve is different size than mine is. So using this aortic valve area seems like a weird way to define it. So if I compare a giant's aortic valve area with a petite woman's aortic valve size, those aren't really comparable, right? So what we need is a way to define those. Well, that is the indexed valve area, and this is indexed by body size, right? So body surface area, meter squared. In this case, the numbers that we're going to use are for severe aortic stenosis. We're going to say that the valve index is less than 0.6. Now, the other things that we use are a mean gradient. So we have peak velocities and mean gradients. When the mean gradient, when we average it over the entire cardiac cycle, is greater than 40 millimeters of mercury, or the velocity is greater than 4 meters per second. All right, so the thing that you're going to focus on when you're a clinician is mostly the valve area, but keep in mind that that really should be indexed to give the best assessment. And there are other ways of doing this. This is sort of the classic way when we talk about looking at the valve area. So mitral regurgitation is leaking of blood backward in the heart. And mitral regurgitation goes from the left ventricle to the left atrium. We talked before about the fact that that is a volume overload problem. When the blood flows from the ventricle into the atrium, that's the wrong direction, right? And what happens is that means every heartbeat, some of that blood goes backward and goes into the lungs. And so over time, this is a volume overload problem that causes that causes systolic failure, right? As the heart muscle weakens from that chronic volume overload, now we have a problem. And in fact, we know that it's time to operate on somebody when they have anything less than perfect cardiac output. So the etiology of mitral regurgitation can come from several different methods or sources. One is mitral valve prolapse. So 30 years ago, we diagnosed mitral valve prolapse all the time based on, some made up echo criteria. But there's mitral valve prolapse that you can hear or that shows up on echo. And we just don't call it as much as we used to because we know that person is not going to convert to any worsening mitral valve prolapse. But then there's mitral valve prolapse, right? Where there's a big floppy valve and it moves in a gross way. And we know that that person may well go on to flail mitral valve leaflet or, flail problem at the where the attachment to the muscle happens. There's different degrees of mitral valve prolapse. So that severe mitral valve prolapse is one of the ways that you can develop mitral regurgitation. Mitral annular calcification. As people get older and calcification occurs, that calcification can change the shape of the annulus so that the valve leaflets don't coapt well. That's another form. If you have somebody with dilated cardiomyopathy, that can change the way that the valve leaflets coapt as well. That's ventricular remodeling. Chordae rupture, pap muscle infarct, endocarditis is another common reason, and of course rheumatic fever are all potential etiologies. So I want you to appreciate how complex this valve is. The aortic valve is pretty simple, right? It's suspended from the aorta and the valve leaflets are there and they work. And when they don't work, there's one reason for that. And that is that there's calcification of the valve or, worsening of function because of a bicuspid valve. That's pretty much it. With the mitral valve, this is a much more complicated valve. And the maker made the valve, this is just a beautiful way to construct this when it works. When it works, we have this annulus that supports the valve structure. And these leaflets then are attached to the heart muscle. Now, why would that be? Well, we want them attached to the heart muscle because when the ventricle contracts, we want some traction to be placed on the valve so that it doesn't flop backward into the atrium. And that's exactly what happens here. So this papillary muscle contraction pulls traction, causes traction to be had on these chordae, which keep the valve from prolapsing back into the atrium. It's just a beautiful thing when it all works together. But the geometry is important. And if you have loss of the heart muscle in the lateral wall, then you have loss of this lateral pap muscle, and that can cause regurgitation. Or the annular calcification can change the shape of the annulus. That means the valve leaflets can't coapt correctly. That could cause regurgitation. There's many different potential sources of regurgitation. So the natural history, again, your body is very good at tolerating this early on in chronic mitral regurgitation. Left atrial enlargement happens, and then pulmonary congestion. As the left atrium enlarges, you often develop atrial fibrillation. The important thing to know is that LV function is not as good as it appears, right? If you have two ways for blood to get out, you have the hard way through the higher pressure aortic valve, or you have the lower pressure mitral valve through which it can get through. That's going to change the contraction of the ventricle, or what it appears like, because now you have this pop-off valve. That means you're going to be able to contract this muscle much more. So if you see normal LV function, that really is not normal, because there's this pop-off valve that's making it easier for blood to get out. So the left ventricular function is never as good as it appears. And by the way, once you see diminishing LV function, remember that this is contributing a sizable portion of that contractility, because it's that pop-off valve again. And so if the ventricular function is already failing, then it may be too late to fix that valve. That's why surgical timing is critical. So remember that with aortic stenosis, we use the events in systole to tell us how severe it is. In mitral regurgitation, we use the events of diastole, because in mitral regurgitation, you have this huge volume of blood that goes backward in the heart, and volume overload problems lead to dilation of the ventricle. And when the ventricle dilates, that's when you may have that huge volume of blood in the atrium that falls into the ventricle and makes a third heart sound. That third heart sound indicates severe mitral regurgitation. Okay, so go back to that slide that shows all of the events in the cardiac cycle, and picture on that slide where the third heart sound occurs. It occurs there because there's a huge volume of blood in the left atrium that's falling into the ventricle. Why is there a huge volume of blood there? Well, because of the regurgitation and the backward flow of blood into the wrong area. Okay? This is echocardiogram showing a wide leaking jet, and that's one of the many criteria that we use by echo to assess severity of mitral regurgitation. It's not worth learning all those criteria. I don't know them all either. I rely on the cardiologist to do all the measurements, and they will tell you whether it's mild, moderate, or severe. Okay. Finally, rheumatic heart disease. Remember that this is caused by group A beta hemolytic strep. We may joke about strep throat and think that it's not a big deal, but it is a big deal, because it can lead to rheumatic heart disease if untreated. Now, the good news is that when we treat it with antibiotics within 9 days of symptom appearance, we can prevent rheumatic heart disease. But we don't want to delay, because antibiotic treatment after 2 weeks of inactive infection does not prevent you from having rheumatic fever. Even if you have beta hemolytic strep infection, only about 10% of those turn into rheumatic heart disease. But still, it's a completely avoidable cause of valvular heart disease. We're going to switch gears and talk about endocarditis, which is an infection directly of the valves. First, why does it happen in some patients and not in other patients? Well, the reason is that there's some abnormality of that valve that is responsible for seeding of the infection on that valve. Well, what can do that? Normally, when you have flow through a system, you have this laminar blood flow, right? It goes in a straight line and there's no turbulence of blood flow through this solid pipe. And when the blood flows through the heart, it should have laminar flow. But if you have some lesions or bumps or any abnormality of valve function, that can cause this turbulent blood flow. And you get this eddy of blood that just keeps hitting the valve apparatus with infection, right? With bacteria. And eventually that bacteria sticks to that and causes an infection. And that's the pathophysiology behind vegetations on valves. There's some abnormality of the valve to begin with. Now, that works, that method of thinking works best for non-IV drug users, for people who have left-sided valvular abnormalities. That's a nice model to think about. But when you think about the right-sided tricuspid valve endocarditis that happens typically with IV drug abusers, that model sort of falls apart. And the way I like to think about the right-sided tricuspid valve abnormality is that it's not a very strong valve and it can't really take a joke, right? So when you shower it with all sorts of trash from dirty needles and all that sort of business, it can't survive long enough because there are numerous changes that happen with that valve in response to volume and all sorts of things that causes an abnormality of blood flow across that valve. And that's where things stick to it and you get this tricuspid infection. So the people at highest risk of endocarditis, and this is an important lesson, are people who've had endocarditis before. They've already proven that they have the substrate, right, for having endocarditis. That substrate doesn't go away. And in fact, even if you have a valve replaced in response to endocarditis, now you have a new valve in there that doesn't function the way the maker intended. And so, there will be abnormalities of flow across an abnormal or prosthetic heart valve. So those patients are at risk. IV drug abusers, patients with congenital heart disease, any implanted device in the heart, whether it's a valve, a pacemaker, what have you. Any of those things increase your risk of endocarditis. And then, of course, any central venous catheter, particularly hemodialysis catheters. Any of those patients require endocarditis prophylaxis when they go to the dentist, and for any other procedures that are termed dirty. So if you have endoscopy with biopsy, if you have a peripheral cellulitis that they're cutting into, those patients need endocarditis prophylaxis. We're not going to talk about that specifically, but just know that that's what you need. So the most often involved valve is the mitral valve, and here is an example of a very ugly looking vegetation on 2 leaflets of the mitral valve. So this should all look like, neat and should sort of look like this segment all the way across. But here's these big giant globs that are on there. The second most commonly infected valve is the aortic valve. The tricuspid valve is usually involved with IV drug abuse. Well, let me say it this way. When we see tricuspid valve endocarditis, it's almost always from IV drug abuse. Okay, and we rarely in adults see pulmonic valve involvement. It used to be that we relied on these Duke criteria quite a bit, but now, as long as you get 2 major criteria, you get positive blood cultures and evidence by echo that's enough. And our echo machines are so good nowadays that we can easily pick out vegetations on most of the valves. And if we can't, then we do a TEE to get crystal clear pictures. So all these minor criteria we don't really play around with as much anymore. They do for subacute bacterial endocarditis, and infectious disease specialists may get involved with that. But we really don't have to worry about most of that anymore because the echoes are so good. What are the complications of endocarditis? Well, remember that this is an infection that can go around the valve as well. So one of the things that can happen is the pieces can break off and go to the body. You can have a stroke, septic stroke. You can have septic emboli to any part of the body, including the gut, the extremities, the brain, wherever. So that's a major consideration. Another one is heart block. Well, how can you have heart block from endocarditis? Well, here's a picture that shows you the non-coronary cusp. So this is the right coronary cusp. This is the one that makes a little pocket here at the right coronary artery. This is the left coronary cusp at the left coronary artery. And this is the non-coronary cusp, but it is right beside the AV node. So sometimes when that infection involves the valve here, it can eat away through the annulus, and that infection can impact the aortic valve or the AV node. And when that happens, you can have heart block. Now, when we treat it, sometimes that heart block goes away, right? But sometimes it's persistent, and they would need a pacemaker. Here are some of the physical findings. If you look at the slide, you'll see the description of all these things. These are splinter hemorrhages, Janeway lesions, and this is conjunctival hemorrhages. These are the criteria that we used to have to add up as minor Duke criteria to get a score and see if their endocarditis is real. These all, as I recall, happen pretty rarely to be useful as diagnostic tools. I think they occur in endocarditis in the neighborhood of 10% of the time. So not terribly helpful. And I always have a splinter hemorrhage on one of my nail beds, just for your purposes there. So what are the diagnostic tests? Well, there's echocardiogram, of course, and these are echocardiogram images of another mitral regurgitation, mitral valve infection. TEE we use very frequently. You can click on this and see a YouTube video of a transesophageal echo. And then, of course, we need blood cultures, and we have to do them right. You have to do it before antibiotics are given. We need 2 sets, 20 minutes apart at separate sites. And we get it every day with fever spikes, right? Until we identify the organism, because we want to use directed therapy. Remember empiric versus directed therapy. We want to use directed therapy so we know exactly what organism we're fixing, and then we give that antibiotic for that period of time. Pericarditis is defined as an inflammation of the pericardium that goes around the heart. And this results in sharp chest pain, not classic angina, but rather sharp pain, hurts worse with a deep breath. And on the EKG, you get this classic diffuse ST elevation. So this is the lateral leads here, and this is the anterior leads here, and these are the inferior leads here, and you can see ST elevation in all of those. Well, that doesn't go along with coronary disease or an MI, but that diffuse ST elevation goes along with pericarditis. Okay? You can have pericarditis, or this inflammation of the pericardial sac, for a variety of reasons. Rarely we get it infectious with viral or bacterial or other types of infection. Radiation can lead to pericarditis. We often see it after cardiac injury, frequently after post-pericardiotomy, where you have median sternotomy incision to do heart surgery, for instance. Those patients often develop, not often, I mean, it's still rare, but we're never surprised when somebody develops pericarditis after pericardiotomy. Drugs and toxins can do it. There's metabolic reasons too, like uremia and myxedema that can make fluid collect in that pericardial sac. Malignancy, especially lung and breast cancers and Hodgkin's lymphoma, collagen vascular disease, and then oftentimes we get this idiopathic, which generally ends up being attributed to some immune modulated reason. Now, the biggest concern when we're talking about pericarditis is the development of cardiac tamponade, where so much fluid, remember that when two surfaces rub together in the body, they often make fluid, and that's what happens in pericarditis. You get the two surfaces that rub together and an effusion occurs, and that effusion can be big enough to cause the heart to not fill anymore. Beck's triad is these three things that occur together, and you should be able to recognize these. One is you see this jugular venous distension. Sit the patient upright in bed, look for veins. If you see them, that's a concern, right? Secondly is muffled heart tones. So because there's this fluid around the heart, it's sort of hard to hear. It sounds like, their heart is stuck underwater, right? So that goes along with tamponade as well. And then because the heart can't fill well when it's tamponading, you get hypotensive as well. So those three things together are concerns for cardiac tamponade, and that's a medical or surgical emergency. Lastly, we're going to talk about shock and mods. When we talked about, or hopefully you watched the video on hemodynamics, so you understand preload and afterload and all that jazz. That will be good for you to watch before you watch this part of the video on shock. So shock is a state of cellular and tissue hypoxia due to reduced oxygen delivery or increased oxygen consumption or inadequate oxygen utilization or some reason involving the oxygen and the tissue hypoxia. All right. There are three major classifications of shock. We have hypovolemic shock, which causes a decreased cardiac output, increase in heart rate, increase in SVR because the vessels are clamping down, trying to increase the blood pressure. We may see a big ejection fraction, normal ejection fraction. But hypovolemia is one type. So you could be bleeding to death. You could be over-diuresed or whatever. You're hypovolemic. The second reason is cardiogenic. So you have a big MI, takes out your entire anterior wall and the apex of your heart, and you're struggling to be able to oxygenate those tissues. That's cardiogenic shock. And then there's this thing called distributive shock. And the most commonly recognized distributive shock is septic shock. Septic shock is distributive because there's plenty of blood or fluid, and there's great contractility. The problem lies in the SVR, right? The vasculature just collapses in septic shock, or other types of distributive shock, which are neurogenic shock and anaphylactic shock. In those cases, the vasculature just quit. The vasculature is done. It is fully dilated, and that gives the impression of hypovolemia. So we treat those patients with tons of volume, right? We give them plenty of volume. The cardiac output may be super high cardiac output because there's no resistance to blood flow, right? The SVR is so low that the cardiac output is just banging. We may see cardiac outputs of 10 liters a minute when we have somebody with distributive shock. So the cardiogenic shock, again, is due to some decrease in the myocardial contractility, whether it's from myocardial infarction or what have you. That leads to decreased contractile force, which decreases the cardiac output. And then the body kicks in and stimulates the renin-angiotensin-aldosterone system to increase the, and also the sympathetic nervous system to increase the heart rate, the preload, the resistance, all those things, which, by the way, increases myocardial demand and oxygen consumption. And all of those things go to increase myocardial ischemia, which further injures it, and this is a vicious cycle. Hypovolemic shock, again, is just fluid loss or hemorrhage or burns or some other reason that you have this massive loss of volume, and that causes decreased venous return, which decreases the cardiac output, and that causes decreased tissue perfusion and decreased oxygenation, and the kidneys respond by holding on to volume, which causes more heart failure from CNS activation and renin-angiotensin-aldosterone, and all of that stuff is not helpful, because the problem really is that you need more volume. Okay. And then again, distributive shock, very straightforward, but it's this relative hypovolemia because there's massive vascular dilation and vascular collapse. So although there's plenty of volume with normal vasculature, now that it's maximally vasodilated, you have this relative hypovolemia. Banging cardiac output or banging heart muscle function, but we need to fill up the tank, give lots of fluid to treat this problem. Okay. Now, we're going to focus on septic shock because it's probably the least intuitive of the shocks. If you have cardiogenic shock, that makes sense. The heart's not working. I got to fix the heart. If you have hypovolemic shock, there's not enough fluid. I got to fix the fluid volume, right? Those make sense intuitively. But with septic shock, it doesn't necessarily make sense that the blood pressure is low when there's plenty of volume and there's plenty of cardiac output. Again, the vasodilation, the massive vascular collapse is the problem there. So let's talk a little bit more about septic shock. When you have septic shock, you have to meet certain criteria, right? But first, a couple of definitions. Infection, of course, is the invasion of normally sterile tissue by organisms, whether it's the blood tissue or the gut or the skin or whatever. That tissue is infected. Bacteremia is presence of the bacterium in the blood. The systemic inflammatory response syndrome is a syndrome that comes from massive inflammatory response, but it doesn't have to be from an infection. That's the critical thing to understand here. Can be from an infection or can be from a non-infectious insult. Okay. Sepsis is the SIRS, systemic inflammatory response syndrome, plus an infection. Severe sepsis is with some organ dysfunction. Septic shock is persistent hypotension despite giving plenty of fluids. And then we're going to talk about MODS in a minute. So the systemic inflammatory response syndrome can happen because of infection or non-infection, right? Like pancreatitis or burns or shock from trauma and fluid loss, right? All of these can be associated with SIRS. In order to have SIRS, you need two of these criteria. Please, please, please memorize this. This is important for you to know. You have two of these criteria, but notice that infection is not included in this, right? When we have two or more of these criteria plus infection, then we say that they have sepsis. But when you just have a fever and a white count, you may have an infection, but maybe not. Maybe you just got some steroids that made you have a white count. Who knows? So sepsis is two or more of these plus infection or presumed infection. And then severe sepsis and septic shock are defined here. Now, multiple organ dysfunction syndrome, or MODS, we're mentioning here because I want you to see how important this is for figuring out who is going to have, who's going to survive from their infection or their whatever shock, and who won't. Well, in fact, we know that the mortality rate of MODS, multi-organ dysfunction syndrome, is 54% when two organ systems are affected. Two organ systems. So what two organ systems? Well, heart and lungs. So if you have somebody on the ventilator and you're supporting their heart with inotropes, that's two systems. They have a 54% mortality rate. When you add in there no neurologic symptoms plus renal failure plus liver failure, that is 100% mortality rate when you have 5 systems involved. Now, what are the etiologies? Well, shock and sepsis are very common causes, but there's any number of other things that can contribute as listed here. The patients at greatest risk for multiple organ dysfunction syndrome will not surprise you. Older adults, young children, those with significant tissue injury or pre-existing disease, like heart failure, like kidney failure, any of those things certainly increase your risk. The way it works is that you have this stress response that occurs, and that kicks in the complement, coagulation, the kinin proteins. All this storm happens that cause a change in the vascular endothelium and leaking through there, and this massive inflammatory syndrome that affects everything. The neutrophils accumulate in the organs, and they are a very important contributor to MODS. Now remember the timeline as well. With at approximately 24 hours, you may see these sorts of things that indicate somebody is super sick. 24 to 72 hours is the beginning of lung failure and maybe the beginning of ARDS. Between 7 and 10 days is when we typically see hepatic, intestinal, and renal failure. And then from 2 to 3 weeks, we see the increase in these effects and death. So that's what I wanted you to know about MODS. We'll finish up briefly with a discussion about dysrhythmias. I'm sorry, I thought that was the last thing, but I forgot about dysrhythmias. I want you to notice here the dysrhythmia mechanism. Remember that we have this action potential that happens here. Starts with phase 0, because I guess physiologists can't count, right? Why would you start at phase 0? Well, whatever. Phase 0 is this period of time and this occurrence where sodium moves into the cell. During phase 1 is where that change in electrical charge occurs across that membrane. At phase 2 is where calcium influx occurs. So calcium moves into the cell. And then phase 3 is where potassium efflux occurs, where the potassium moves out. And the sodium-potassium pump starts later in that toward phase 4. That sodium-potassium pump then re-equilibrates the two ions, and then we get back to the resting potential at phase 4. Now, different types of tissue have different shapes of their action potential. And I just show this to you so that you have some idea of why the SA node happens to change rates, right? Well, it changes rates because of this ability to change phase 4. Once the action potential finishes and you get back to phase 4, then you can adjust the speed of the speed of the heart, or the heart rate, by changing the slope of phase 4. And that's what the SA node does. But notice there's none of that happens in the atrium or the ventricles, right? That is just an all or none response that happens here in phase 4 or in phase 0 when this begins. This is a flat line. This is a flat line in both the atria and the ventricles. And that's why when you have a ventricular escape rhythm, the heart rate is 20 to 40, right? Because that is the rate that it goes at. But the SA node can change its rate. And this is how it does it, by adjusting the slope of phase 4. I thought that was interesting. The normal conduction, remember, goes from the SA node down the Bachmann's bundle to the left atrium and then hits the AV node. The AV node then transmits the signal after a brief period of time. That brief period of time, by the way, is so the ventricles can fill, right? So that PR interval is the distance or is the time that the impulse waits in the AV node before getting sent down to the bundle of His, and then the bundles in the Purkinje system. So there are intrinsic rates of cells. Remember, all myocardiocytes have the ability to stimulate the heartbeat or to act as pacemakers of the heart. When the SA node is in charge, the heart rate is generally between 60 to 100. When the atrial cells are in charge, it's 55 to 60. The AV node rate is 40 to 60-ish. And the Purkinje cells are in the neighborhood of 35 to 40. And the myocardial cells themselves are lower than that yet. So all of these, we can tell what which part of the heart is initiating the pacemaking by just knowing the heart rate. So remember all the intervals and segments, and I will not bore you with that because you hopefully know that. Remember that we can see conduction system disease when we look at the heart rate and when we look at the PR interval. We see conduction in the ventricles fail when we see bundle branch blocks and things like that, and fascicular blocks. So let's talk about the first symptom of, or the first sign, I should say, of conduction system disease, the first degree AV block. When we see first degree AV block, we see a prolonged PR interval. So the PR is from the beginning of the P to the beginning of the QRS, not to the peak of the R wave, the beginning of the QRS. And so that indicates that there's some disease here of conduction through this part of the AV node. Second degree can be physiologic. Now, I want you to know that this is characterized by group beating. Remember the long, longer, longest, dropped. Now I have a Wenke Bach. Remember that little rhyme that you learned in undergrad? Well, what happens here, and the reason this can be physiologic, is that some people just, this is the way the AV node works. As the fibers here become more refractory, we have this lengthening of the PR interval. This is totally normal, and you may have it. It may be that your patient has it, and when we see asymptomatic Wenckebach, there's nothing to do. It doesn't naturally progress to type 2. There's nothing that you can say about this other than they have Wenckebach, and that's kind of a physiologic thing that just happens. Okay? By the way, grouped beating is where you look at a strip and you see there's this length of QRSs, the Q to Q is persistent. Then there's a lengthening of the Q to Q. And when you look at this, if this happens every 4 beats, you'll see grouped beating of, 4 beats, then 4 beats, then 4 beats, separated by this lengthened period of time where there's no QRS in response. So grouped beating, whenever you see grouped beating, you should first think Wenckebach. Second degree is a whole different animal. This is where the PR interval is the same, and then suddenly there's a loss of conduction. Then back to a normal PR interval, loss of conduction. That is a more worrisome thing, and these patients usually end up going on to need a pacemaker. If they don't get a pacemaker, they devolve into this, which is third degree AV block, or dissociation between the atria and the ventricles. You can see that the atria are doing their thing. You can see a normal P to P all the way through here. The P waves may get buried in this T wave. You can see the other P wave right here. Then it just keeps marching through, and there's another P wave buried in that T wave, and these just keep marching through. They do their own thing, and the ventricle is doing its own thing. See that normal or that consistent R to R? This is complete AV dissociation. The atria are doing their thing, the ventricles are doing their thing, and this needs a pacemaker because you have to resynchronize the heart. Now, what about bundle branch blocks? Well, I want you to know what the criteria are for bundle branch blocks. For a right bundle branch block, if we look at the V leads, you can see that there's this RSR prime at V1. And that means that there's a block in the conduction system. And here there's a wide S wave in V5 and V6. See that wide S wave? It takes longer to get to the T wave. This is classic right bundle branch block pattern. With a left bundle branch block pattern, it's just the opposite. You have the RSR prime here, there's an R, there's the R prime in V5 or V6, and you have the wide S wave here in V1 or V2. You see that? So that is the classic left bundle branch block. I want you to know that you have to see this on a 12-lead EKG in order to call a bundle branch block. When you see this configuration on a rhythm strip, who knows what it is, right? It could be intraventricular conduction delay, whatever. You can't make the call that it's a right bundle branch block unless you see it on a 12-lead EKG, because these are the criteria. Notice it doesn't, you can't make that call about the V1, V2, or V5, V6 with just a rhythm strip. All right. Now, the last thing to discuss is this mechanism of dysrhythmias. There are 3 major mechanisms of dysrhythmias. First is an automatic dysrhythmia. This would be like atrial tachycardia, for instance. In atrial tachycardia, you may have a bunch of cells somewhere in the atrium that are conspiring to cause a sudden onset of tachycardia. And that is what we call an automatic focus. Atrial tachycardia is classic. There's, the competing pacemaker cells, the SA node, and then this other weird set of children who play in another part of the atrium, and they conspire to cause this tachycardia to happen. So what we do there is we use a catheter ablation technique to just zap that excess site and make it stop. There may be triggered activity too. you may have some conduction abnormality that triggers another arrhythmia. But the most common rhythm disorder that we see is, and I'm not even talking about atrial fibrillation, but re-entry. So re-entry is a very common cause of SVT. In order for you to have re-entry, you have to have three things present, and they are shown right here in this flask model, right? Kind of looks like one of those flasks. I forget what kind of flask that is. Erlenmeyer flask? That's where you have the little triangular base with a tall neck. Well, what happens here is that you have two pathways, pathway 1 and pathway 2. And normally it should function this way. The impulse comes down here and goes in both directions, and when it meets here in the middle, it just stops. But when you have a reentrant tachycardia or a reentrant arrhythmia, you have these dual pathways through the AV node, and you have a fast pathway and a slow pathway shown in blue here. And so all of this signal comes down and it goes across here and back up through the AV node, and that slow pathway causes this cycle to happen. Okay, and that cycle is what happens in the most common type of arrhythmia for SVT, the reentrant tachycardia. I also have to mention that there's block that happens. I'm sorry, I forgot that part. So the impulse comes down one pathway and tries to go down this pathway, but it gets blocked. And now instead you have reverse conduction that comes up the slow pathway that makes that cycle happen. So you need those three things. You need a dual pathway, fast and slow. You need retrograde conduction, that's this, going backward. And you need block right here where it can't get past this in the anterograde conduction. That's how most SVTs work, like AV nodal reentrant tachycardia, for instance. But everybody knows the most annoying dysrhythmia is atrial fibrillation. We deal with it constantly, and it's just a major pain in the neck. Not only is it a pain in the neck to deal with, but it also has some pretty serious association with stroke. And so when we have somebody who has atrial fibrillation, we have to anticoagulate them and control their heart rate. And sometimes we try to convert them to a normal rhythm. But those are things to be dealt with during your medicine classes. Risk factors for atrial fibrillation include advancing age. I tell patients that as you get older, the wiring in your heart wears out, just like it does in your house, and you have to replace it once in a while. Sometimes we need to treat the wiring in your heart. High blood pressure, obesity, European ancestry, diabetes, heart failure, you can read the rest of them here. All of those are associated with a higher incidence or higher likelihood of having atrial fibrillation. Supraventricular tachycardia, again, a commonly seen dysrhythmia. And the definition loosely is any tachycardia that is 150 beats per minute or greater. And then ventricular tachycardia is the more worrisome of the tachycardias because it's originating in the ventricles. And that needs emergency attention. So that's what I wanted to tell you about today. There will be the usual assignments online, and as usual, get in touch with me if you have any questions.